Okay, when we shift gears, we're going to go to child and adolescent and talk a little bit about child and adolescent. And the presenter tonight is the actual track coordinator, which is Dr. Bill McGee, and so he's going to come up and talk about that.
Because when we talk about children and adolescents, one of the things that we do is we talk about working with folks that are a lot more fun to work with than us adults. I don't have a PowerPoint presentation, so I don't know what to do with my hands, so I'm just going to walk. And so when we talk about child and adolescent counseling, one of the things that we do is we talk about figuring out what's normal versus what's not normal, right? We're not going to do counseling with something that's just smack dab in the middle of the road normal. And the most common problem that presents with therapists that work with children and adolescents is ADHD. So is there anybody here who's never heard of like ADHD? Attention deficit hyperactivity disorder, okay? And in our profession, a disorder tends to be those things that just get in the way. They get in the way. So I'm not going to do it, but if we were to walk through all the symptoms in the diagnostic manual that describe ADHD, we've got about 9 for inattention, we've got 9 for hyperactivity and impulsivity. If we were to just walk through those, and I would ask, which I might do in a class, ask for a show of hands, how many show this symptom, how many show this symptom. Pretty much everybody's going to raise their hands on almost every symptom. But the key difference is going to be how often does the symptom occur, what difficulty or what level of difficulty does the symptom present, and is it outside the realm of what is developmentally normal. For example, if we look just at attention, a 10-year-old's level of attention compared to a 15-year-old's level of attention, we would expect to be pretty different. A 5-year-old's level of attention versus a 10-year-old's, again, we would expect that to be pretty different. And so it's not a one-size-fits-all. It's a does it get in the way or not. So let's say that we have a child who comes in with symptoms of ADHD, has a diagnosis maybe of ADHD, and our job is to work with the child or the parent maybe, the child or the teenager. It might be a teenager that comes in, and certainly with the parent or parents, and most often just with the family system. The child is, I'm just going to say child, the child is going to be the identified patient, but it's very difficult to work. In fact, I can't imagine working with a child outside the context of the family, so we have to have some family involvement too. But when we look at ADHD, one of the most common concerns that I hear from parents is, I hear a lot of common concerns. One of the most common ones that I hear from parents is, is my child going to have to take medicine for the rest of his life? Is he going to be able to go to college? Is he going to be able to have a normal life? The normal life is the big concern that most parents express. So one of the things that's really important to do as a therapist is to talk to parents about exactly what ADHD is, and that's what I'm going to do this evening. So when we look at ADHD, attention deficit hyperactivity disorder, if we look at it historically, it showed up in what we call the DSM-3, the 3rd edition of the diagnostic manual. I was trained on DSM-2 because I'm like really old, and that was a long time ago. And I don't know if any of my students have ever seen the DSM-2, but it was small, very small. And there was no diagnosis for ADD or ADHD. There were 3 different clinical diagnoses that we could use because the way we conceptualized ADHD was so different way back then. And so the 3 different clinical disorders that we could have put somebody with ADHD in, the first was dyslexia. And of course, ADHD is not dyslexia, but that was one of the categories that we would use for it or could use for it. A second one, which is almost my all-time favorite, is minimal brain dysfunction. Wouldn't you like to take your kid in and get a diagnosis like that? What's wrong with my kid? Well, it's just minimal brain dysfunction. Yeah, that'll lighten your heart. And the third is actually my all-time favorite diagnosis, period. Hyperkinetic reaction to childhood. I never knew exactly what that meant, but it sounded really cool, and I really like it. So we had those three to choose from. With the advent of DSM-3, which was much more research-based, we began to conceptualize ADHD in a very different way. Prior to that, we saw the primary dysfunction, if you will, or the primary impairment in ADHD as hyperactivity. And if we're going to treat hyperactivity with stimulant meds, which is usually the way it's going to be treated, you have to give enough medicine so that the child is essentially sedated. So you get that nice zombie effect, okay, which parents, generally speaking, don't want. And in my view, that's bad treatment. But when we started looking at ADHD and conceptualizing it the way we do now, what we began to realize was hyperactivity is like not really a problem unless it's associated with impulsivity. The impulsivity is the real issue there. And certainly difficulty with attentional focus, being able to kind of stay focused on something, what we call maintaining mental effort or showing sustained mental effort. So the whole focus of treatment began to change. And so what we do now is we talk about not so much hyperactivity. Again, hyperactivity is not really an issue. It's impulsivity, it's inattention that become the issue. And so when I talk to parents, one of the things that I describe, and it depends a little bit on the parent and the level of, if you will, psychological sophistication, but one of the things that I simply tell them is that when we look at ADHD, or when we treat somebody with ADHD, we're not trying to fix anything because there's nothing broken, and we're not trying to cure anything because it's not an illness or a disease. What we're doing is we're trying to help the individual, the child, be better able to harness what he or she has. That's really what it's about. So when we look at where ADHD tends to show impairment, the primary setting, I think everybody knows this, is going to be in any kind of school placement, any kind of educational placement. That's where ADHD is almost always a disorder, almost always gets in the way. But the second most common place for symptoms of ADHD to be problematic are in the interpersonal realm, social relationships, okay? And so those are the two areas that we can focus on. When we talk about treating ADHD, we talk about, or I talk about, operating rules. Okay? Anybody here ever use a computer? Come on, students, you know you get questions like this. Okay. Almost everybody has used a computer. That's good. And how many of you use a MacBook or some version of a Mac? And how many of you use the other kind, the IBM platform? Okay, which one's better? If you use a Mac, you're going to tell me it's a Mac. If you use the IBM, I don't know what you'll tell me, okay? But what's the difference in those two kinds of computers? What's the difference? Preference. Well, preference is certainly a difference. How they work, yeah. What's the difference in how they work? Different operating systems, exactly. And so when we talk about folks with ADHD, an easy way to kind of move into how we're going to harness it, how we're going to work with it, is we simply talk about different operating systems, okay? And if we have a different operating system, like my son-in-law has a MacBook, and he swears by it. He says it's the best thing ever made, and every time they come out with a new one, you know, he wants to get the new one because it's better than the one before it, and it's all better than any IBM stuff. He's a real tech kind of guy. So in terms of how the computers work, my very simplistic conceptualization is with any kind of computer, we take stuff that we're going to put into it, right? It goes into a processor and we get data out. We get something out, okay? How the processor makes that happen, I don't know. And I don't really feel, I don't have one of those inquiring minds when it comes to the processor itself. But when it comes to kids with ADHD or teenagers with ADHD or even adults with ADHD, yeah, now it begins to have some relevance. And so we talk about operating rules. For example, is anybody here a teacher or been a teacher? Ooh, several of you. Anybody here ever had a teacher? Good. I'm glad to know that. And so if you're a teacher, or if you've had a teacher, or if you have a child who's had a teacher, what you know is that what teachers do, and I remember this, I'm like older than everybody in the room, and I still remember that what teachers used to say, and they still say it, is some version of this. Okay, boys and girls, you're in my classroom and I want you to pay attention. And this is the way you're going to pay attention. I want you to sit up straight in your seat. I want you to put your feet flat on the floor. I want you to look at me, and I want you to, are you ready? Pay attention. So, and teachers still say that. And the reason they still say it is that for about 90 to 94% of the population, it works. They can do it. But for the ADHD population, for the 6 to 8, maybe 9% of the population which has ADHD, assuming that the child is compliant to some extent, they will attempt to pay attention that way and find that it doesn't work. And they will try again, and they will find that it doesn't work. And at some point, they'll quit trying. But they'll try a lot, and their conclusion will be that there's something wrong with them, or they're doing it wrong, okay? Well, in reality, what happens is we have a different operating system, which means we have different operating rules. Most everybody in here is going to be able to pay attention just fine the way I described, the way the teacher sets it up. But if we have somebody with ADHD, folks with ADHD are pretty much put together to scan their environment. And they're really good at it. My students know that I like to hike and so on. And so if I take somebody with me with ADHD, what's going to happen is they're likely to be the first person to spot anything that's new, unique, novel, out of the ordinary. They're likely to be the first person to spot danger, first person to spot a food source if we're looking for that, first person to spot a water source if we're looking for that, and so on. So it works really well if you're out backpacking with me. But if you're sitting in a classroom, it doesn't work real well because you're sitting. So one of the operating rules that we know that we use with folks with ADHD is folks with ADHD tend to be able to sustain attention much more efficiently, and therefore to learn much more efficiently if they are moving. Moving, okay? Is that cool or what? Isn't that good to know? And so when I'm talking to parents with kids with ADHD and they're telling me what a nightmare homework is, and if you work with kids, you'll work with kids with ADHD, and if you work with kids with ADHD, you'll talk to parents who have kids with ADHD, and they will say the same thing. Homework time is a nightmare. And so one of the things that we can do is we can change the way they structure it. We allow the child to stand or sit or lie on the floor or, I don't know, any way that we can think of just to allow them the option or the opportunity to move. I had one mom, I'd seen this child, her child for a little while, teenager, 15, maybe 16 years old. We got everybody kind of squared away, and then I didn't see them for about 6 months, 7 months, and all of a sudden I got a panicky phone call from mom. And we scheduled mom in. And she came in, and her concern, of course, was her daughter's study habits. And she said, I don't remember all that she said, but the gist of what she said was, I want to know, and we had daughter in there too, I want to know if it's possible for my daughter to be able to really study if she's in her bedroom, lying on the floor, with her feet up on the bed, with the music going. I said, well, I don't know if it would be possible for me to study like that, but let me ask you something, Mom. What kind of grades is your daughter making? Well, she's making all A's. I said, well, it seems to me that, yeah, she can probably study that way. Okay, and I had to remind her what some of the operating rules are for ADHD. Okay. I have no idea what time I started, so I have no idea. I've got 2 minutes. I can't talk that fast. Well, that gives you, that's just an example of how we can make use of just one of the operating rules when it comes to dealing with kids, teenagers, even adults in college, think about it, with ADHD. In the child and adolescent track, there are 4 courses: child psychopathology, counseling with children, counseling with adolescents, and of course my favorite, advanced counseling with children and adolescents, because I teach that. So one of the things that we do in that, kind of the second half of that course, is we do special topics, and we'll talk about ADHD. We can talk about whatever topic students want to talk about, but ADHD, Asperger's, which now is subsumed under the autism spectrum umbrella. We can talk about problems with kids who can't separate from parents at night. They have to have a parent with them to sleep, and so on. Any number of special topics. And I'm just going to tell you, it's just, and my students know this, so, or know I'm going to say it, or will recognize it at least when I say it. It's so much more fun to work with kids than to work with somebody my age. I mean, think about it. Would you want to work with me, or would you want to work with a kid? Okay? So I think I've used my allotted time. Okay.
Child and adolescent, I remember Dr. Sizemore telling me he loves working with kids because he gets to be a 6-year-old, he gets to be an 8-year-old, and a 12-year-old all in the same day. And he never wears a tie because, you don't wear ties when you work with kids, otherwise you get strangled. Yeah, they are. And you think of such is the kingdom of God, really. He said, suffer little children to come unto me. What a ministry to help a child realize that he's not damaged and he's not defective, but he has a different operating system. And how can you interact with them in some way to draw that out? And the unique part about this particular certificate here at this campus, okay, you have 4 people up in Henniger Counseling Center that counsel child and adolescent people. Dr. McGee, Dr. Thompson, Dr. Skidmore, and Dr. Sizemore. And you can actually have supervision with each of those individuals when you go through your program. And Dr. Thompson has parent-child interaction training as a trainer, which is a unique program for dealing with kids regarding, it's basically a combination of behavioral and reality therapy on how to deal with pretty disruptive kids from a parenting management standpoint. So that's a really neat thing that Richmont offers that you won't get other places. So that's the child and adolescent certificate.